Welcome to Your Need to Know. I'm your host, Catherine Reed, and today we're going to be talking about addiction. And we're going to be talking about addiction with Joshua Cagney, who is the Communications Director with New Paradigm Recovery. Thank you so much for being here, Joshua.
It's my pleasure, Catherine. Thank you for having me.
So addiction, it's a huge topic. And people at this point seem to think that addiction means opioids, and certainly that is an addiction. But at New Paradigm Recovery, you treat addiction in a far more holistic way by recognizing it for what it is. And I'd like for you to kind of elucidate for our viewers the whole scope of addiction and how you approach it at New Paradigm.
Absolutely. So I think that there are a couple of things that have led us to a point, my partners and I, where we decided to found New Paradigm Recovery. We do take a very holistic and comprehensive approach to treatment simply because there is no one-size-fits-all solution for any man or woman who's struggling through recovery and addiction. The second thing that I think is critical to understand is that there's a family component associated with addiction where if we're not actively treating the family, but instead focusing on one individual, then the same problems that brought that person into addiction in the first place probably are going to bring the person back to addiction, right?
Right.
So relapse is something that's very, very important to us. When we think of addiction as a process of an individual's mental health condition, then we need to look deeper. So I think, socially look at addiction as the problem. And for those of us who work in the treatment field and those who are in recovery, they understand that addiction is symptomatic of a larger issue. So our goal, and I think for a lot of centers that are doing well these days, they're trying to treat the underlying disorders. Okay, so whether that be an issue of bipolar disorder, whether that be a schizoid affective disorder, whether that be a depressive disorder, any mental illness or mental disorder that is fueling the need for self-medication and seeking some sort of outside influence to be able to cure what's inside, getting to those underlying disorders and treating those is really the focus of what we're trying to accomplish.
And you come from a unique perspective, you and your founders, because you are in recovery. And is recovery something that ever really ends?
I think that's a matter of opinion and interpretation. My answer is no. I don't think that recovery is an end goal. I think that it's a lifelong process. So I have 3 partners, and we're all in long-term recovery. Most of us better than 15 years. So for us, we've seen both sides of the fence. We've seen it from the active addiction role, and thankfully we've been able to enjoy the fruits of recovery as well. But we've also been able to see sides of treatment that are lacking. I think that we've been able to identify over the last few years, in particular with the opioid epidemic, some of the shortcomings that we have from a social approach. And I say that, I think that it includes the treatment industry, I think that it includes the pharmaceutical industry, I think it includes law enforcement and social services, all of the above, right? So our goal ultimately is to try and create a better approach to managing care and ensure that recovery is a process that everyone can engage in for the duration of their lives, never having to deal with active addiction again.
You have a variety of programs. In fact, it's quite enormous in how you, I want to say, slice and dice this very huge thing into, as you said, sort of the source of the addiction, addressing the source that might be trauma, that might be co-diagnosis of addiction with something else. But you don't have it in one big bucket. You actually have these programs and I think that is helpful for families trying to figure out what is the best approach and how you're different from what other programs have to offer.
I think it's imperative that we approach it through the lens of trying to not identify a person's individual addiction, but identify their underlying disorder. So I think that there are some common denominators when it comes to dealing with addiction. I think that we can look at traumatic influence as a source, or at least influence, in a person's active addiction. I think that we can look at attachment issues, the ability to really develop meaningful, solid relationships with another human being as a source, or at least a byproduct of the addiction. So in terms of the scope of services that we offer, I think it's important to understand that we're not offering a wealth of services as much as it is we're trying to ensure that we have the resources available to address individual issues. Because again, your issues are going to be different than mine. And I cannot take a one-size-fits-all approach. I would suggest that the mentality that we can take a one-size-fits-all approach to treatment is what has created half of the mess that we're in terms of addiction treatment. Take, for example, the 28-day model of residential treatment that we've heard for years is the solution to recovery. If someone comes to me with alcoholism, I put them in treatment for 28 days and that will fix them. But that model doesn't work. It's a dated model that's based on a military interpretation. What we see now, and what I think professionals in the field are beginning to understand, is that as recovery is a lifelong process, treatment needs to be an extended care model, and not one that removes the individual from the home in most cases, but keeps them in the situation and helps them develop coping mechanisms so that they're able to navigate the trials and tribulations of daily life, the same ones that they would encounter if they were at home not in treatment.
And you make a really important point about being a non-residential treatment program. You know, a lot of times people send them to a center, get them dried out. I think about the Betty Ford Clinic back in its day and how people were astonished at her being so forthright about her addiction issues. And so celebrities have gone to the Betty Ford Clinic for decades and decades. And so you go away somewhere and they fix you and then you go home. But to your point, it doesn't work that way because you're going back to exactly the situation that produced the influence that brought you to addiction. So being an outpatient program means that you're working with the family and you're putting that person every day into their real life. Like you're not taking them out of their real life. You're taking them part-time to address so they can, I guess it's like building muscle. You're trying to teach them.
I think that's a great analogy.
You're building muscle so they can keep going back to the life that they live with a better idea of how to fight the addiction and find other ways of coping with what led them there.
Well, the sorts of issues that I face today at home or at work are going to be different than the issues that I face a week from now, right? So my goal is to be able to bring clients in and help them address those issues on a daily basis, and then in the process start to identify and understand the thought processes and the behavioral patterns that sort of create, if not at least exacerbate, problems that they're experiencing in their daily lives. Those are the coping mechanisms that we're really trying to help a person understand and integrate into their life. But they're also the problems that I'm never going to be able to identify in a person's life if I send them off 300 miles away to a 30-day detox and rehabilitation program.
Right, and there are triggers, aren't there? So you can send somebody away and dry them out or get them off, temporarily off the drugs, but we all have triggers. I mean, just normally all of us are triggered. You know, you smell a cinnamon roll and you want to have coffee. You know, people need to have a cigarette with their coffee. You know, there are certain things that just trigger a certain response, and that is memory muscle that says, well, I'm detecting this thing, and so this is what I normally do. So this is kind of helping people to understand too, what is triggering them to respond automatically.
Absolutely, and in a residential environment, they would never see those things 9 times out of 10. So the difference between an outpatient program, and there are multiple tiers of outpatient treatment that range anywhere from a couple of hours a week that a person would regularly go see a therapist, to the other extreme where they're in actual outpatient care for 6 to 8 hours a day, 5 or 6 days a week, where we're referring to partial hospitalization, right? So we are sort of in a medium where we are offering 9 to 15 hours a week of group, individual, and family care. And the goal really is to bring in all those facets of the individual's life so that we can really sort out what the issues are that the individual faces on a daily routine, and then help them navigate that better. Figure out over a period of 3 to 6 months, how can we deal with this in a better way so that the alternative isn't using drugs or alcohol to sort of self-medicate and insulate yourself from those sorts of problems?
So there are people who have whatever kind of addiction, and again, it's not the type of addiction. Addiction is what we do to self-medicate a problem or how we feel or our fear. So you have high functioning people, people who manage for a very long time to treat their inner turmoil with whether it's drugs or it's alcohol, and they go along until something happens. And then there's an event that kind of forces them to face having to do something about it. You know, on the spectrum, the people who come to New Paradigm, are you seeing, you know, people who've managed their lives up to a certain point and have just gotten to a point where they just can't function anymore?
I think that's a great question, and I'm going to give you sort of an interesting answer. If we look at the American Medical Association's interpretation of addiction as a disease, I would caution people to understand the nature of alcoholism and addiction as a disease in the sense that it is the only disease that a person has that will tell you that you don't have a disease, that it's everyone else who has a problem, right? So when people come to us or to any treatment center, it's not because they hit a point where they think, I think I'm drinking too much, or my cocaine use just really isn't helping my life. It's usually an external influence. A husband, a wife, a parent, a coworker, someone who says, listen, I've gone as far with you as I'm willing to go. We need to do something different. And if you don't do this with me, then we're going to go our separate ways. So it's those external influences that are really critical. And on the other hand, that's exactly why we see family as a critical part of treatment and a critical part of rehabilitation and recovery.
And that makes sense because nobody is anywhere alone. Nobody, and I think addiction's very isolating too. When you self-medicate, no matter what it is, it's you are dealing with an internal voice or an internal fear, and you are separated from your family and from your community mainly because you're hiding something. You know, and so how much of addiction really overlaps into mental health treatment?
I would suggest to you that 100% of it is mental health treatment. I think that we as a society have really done ourselves a disservice by debating the merits of whether addiction is a mental health issue or not. I think that it's become so pervasive now, and I'm hesitant to say this, but the opioid epidemic has really sort of accentuated this to the extent that we can no longer afford to think of this as a problem that we can put away. And we're having very healthy conversations about it. It's important.
And I think the opioid epidemic also has affected a different group of people maybe than before. When it was a crack epidemic, you know, people were put in jail. Now it's an opioid epidemic that is in the suburbs and it's in middle-class America. And we can't just brush it aside because it's affecting people who are at the center of our communities. And when we come back from this break, I want to talk further with Joshua Cagney of New Paradigm Recovery. So please join us after the break.
Mrs. and Mrs. Jimmy.
I came from 5 generations of teachers. Losing my job was the bottom falling out of my world.
Awkward. I'm the awkward silence. You try to avoid me, then there I am again.
But an awkward silence can be a great thing.
Like Kelly here is about to demonstrate.
You haven't really been yourself lately. Are you okay?
Find out how you can help a friend with their mental health at seizetheawkward.org.
Operation Wonder Park is a go!
There's nothing more powerful than imagination.
Honey, have you seen my cell phone?
But don't just imagine.
My park came to life?
Ooh, a plot twist.
Use STEM to build, create,
She did it.
and change the world.
Who's with me?
I'm more of a 2 feet on the ground kind of guy. It's gonna hurt tomorrow.
If she can STEM, so can you. Find out more at She Can STEM.
Welcome back to Your Need to Know. I'm your host, Catherine Reed, And today we're talking about addiction with Joshua Cagney, who is the Communications Director for New Paradigm Recovery. Thank you again for being here.
My pleasure.
This is a huge issue, and when we went on break, we were talking about the opioid crisis and why suddenly the conversation has changed and the people having the conversation have changed. Give us some idea of where you see that coming from.
Well, I'll tell you, the opioid epidemic is really a double-edged sword for me personally. There is a struggle that I have, and I think a lot of people in the profession have, terming the opioid issue as an epidemic. We don't like to think of the opioid epidemic as being just a problem with opioids. This is an addiction problem. We don't have an opioid epidemic, we have an addiction epidemic. And it's a continuation of the crystal methamphetamine epidemic that we had 10 years ago, the crack epidemic that we had 20 years ago, the cocaine epidemic that we had 30 years ago, and the heroin epidemic that we had 40 years ago in the 70s. So the nature of addiction hasn't changed. What has changed is the flavor of the day. So a segue into your question, though, is why are we having this conversation now? Quite frankly, because opioids are all based on pharmaceutical grade painkillers, right? So we're talking about Oxycontin, Percocet, hydrocodone, Vicodin, Demerol. These are all things that are prescribed over the counter on a daily basis for anything from I just banged my elbow against the door frame to I just had a knee replacement surgery.
How about wisdom teeth?
Wisdom teeth are another
And who
one.
has their wisdom teeth removed?
Absolutely 98% of the population.
Right, when they're young.
Right.
Teenagers, early 20s, and then they're given this vial of way too many Oxycontin or oxycodone. And I've had surgery. I think there's probably not a person viewing this show who's not been given a prescription painkiller at some point for something. And way too many of them, because until the police had the drug take back, they were just sitting in my medicine cabinet, just sitting there for like 3 years.
And we think that they're okay because the doctor says when the pain starts, take this. This will stop it. And we associate our doctors as being trustworthy. And it's not to take anything away from the medical community, but not having an educational understanding of what these drugs are really doing to our bodies and how they're altering the chemistry of our brain makes a fundamental difference in terms of how we approach taking these things to stop pain. So the way this is changing now is opioids are affecting high school kids who are hurt playing football, college athletes, professional athletes. We're not talking about an inner city problem with crack. We're not talking about a rural America issue with crystal methamphetamine. We're not talking about a cocaine issue that exists only in Florida. We're talking about the nature of addiction as it exists with kids who are between the ages of 15 and 25 years old, who come from upper class and middle class backgrounds. And this is, I hate to sound racial about it, but this is white suburban America that's now being affected by this problem. And we can no longer afford to really not talk about it. We have to talk about it.
Because so many families are affected. I mean,
Millions.
the neighbors are affected, but this brings up a whole other issue about stigma and refusing to share. In the book Dreamland, way back in 2006, there was a case here in Virginia. It was the first case against Purdue Pharmaceutical, but why was it not headlines then? You know, why didn't we know how pervasive it was? It's because families weren't telling their faith communities, they weren't telling their neighbors, they weren't sharing with the school that their child had died of a drug overdose. We did not trust people within our own community to embrace us, to understand, to support us.
And honestly, Catherine, I think that's the biggest tragedy of how addiction has just ravaged this country for the better part of 100 years. We've made the mistake of letting fear guide a lot of our decision making, not just in terms of addiction, but in terms of how we look at addiction and how we treat addiction in our own families and communities. So when we think about if a friend of mine came to me, a coworker or a personal friend came to me and said, my son or my daughter has an addiction problem, I don't know how to handle it, I may not have an immediate solution, but at least I can be there for them. At least I can offer some compassion and some support along the way. I'm not going to assign any shame to that individual. I'm not going to make them feel guilty. I don't see it as a personal character defect of the individual as a parent. This is something that's pervasive in all of our lives, right? But if it's my child, if it's my spouse, then I want to absorb all of this guilt and shame and say, well, I can't let anyone know about this because it's going to reflect poorly on me. So the nature of getting past that fear is not just critical in terms of helping ourselves feel empowered in finding a solution, but it also helps society move forward and getting away from silly debates about the social stigma of mental illness. There should be no social stigma about it. It simply is a matter of life and the way that we're constructed.
And it's so damaging to try to hide something that needs support. You know, I grew up in the 60s and the 70s where you didn't talk about alcoholism or mental illness. I lived that because I had both in my family, you know, and you're so afraid someone's going to find out. And we still to this day treat addiction like it's a personal failure of character. Like, what is wrong with your child or what is wrong with your spouse that they have an addiction? And this blaming and shaming game is one of the reasons that people, I think, are afraid to say, I'm suffering, my family's suffering. And oftentimes there's not anything we can do except to say, well, I'm here to support you and I understand. And this must be terrible, and call me, or I can come be with you. You know, tell me what it is I can do. We are still not seeing that.
No, we're not. And I think that's really, getting past that is going to create long-term macro-size solutions, right? So the fear that motivates a lot of us to both stigmatize mental illness and also absorb that so that we want to be protective and defensive about our own issues in our families and in ourselves, has created this sort of pervasive social idea that politicians and law enforcement are responsible for a solution, right? They're not. You know, the war on drugs has been waged now for 50 years, and I'm not going to get into a political debate about the merits of that, but I am going to point out the fact that we have more people addicted in this country now on an exponential level than we did when the war on drugs started in 1971. So that's not working, right? The idea that law enforcement is going to be able to solve the problem, that's not going to work either. Police officers are hired for a very specific function and they're excellent at what they do, but they're not social workers. They're not drug treatment counselors, and most of them are not in recovery so that they understand intuitively the issues that families and addicts are facing. So we need to think larger in terms of how do we really come up with a good resource set that's appropriate to deal with the problems that we're going to face. Law enforcement and political movements are all important in terms of supporting that and creating a conduit that's going to make that successful, but they're not going to be the solution to it.
And what about the medical profession? And this is why I'm going to ask you. Besides being the source of a lot of these painkillers that have led to widespread addiction right out of your medicine cabinet, not the local dealer on the corner, what about collecting data on things like alcoholism, mental illness, suicide? My sister, when she went, had a new doctor in Atlanta, a woman doctor, and this woman asked her these things. And my sister's like, this is the first time anyone has asked me. I mean, they ask you about high blood pressure and who had a heart attack and who's had diabetes and cancer, but no doctor had ever said, is there a history of mental illness, alcoholism, you know, suicide. Right. And my sister was stunned. But I'm thinking, why doesn't every physician ask this? Because clearly there are patterns. Addiction is more than just the availability of alcohol and drugs.
Well, I think the medical community is really rooted in something that existed long before any of us had a concept of the nuance of psychology or psychiatry, right? So they still sort of go back to their roots when they're concerned about something that they don't intuitively understand. The medical community, like law enforcement, they're phenomenal at what they do. When it comes to creating an addiction problem, or at least exacerbating the issue, I can't lay that at the feet of the medical community. I can lay it at the feet of the pharmaceutical industry because they're motivated entirely by dollars and cents and where their greatest profit is going to come from, and it's going to come from painkillers that are effective without any concern about the side effects or the addictive nature of the pharmaceuticals that they're putting on the market. Doctors' jobs are ultimately to dole out the most effective painkiller that they're given based upon the feedback that they're getting from a client. And they're not going to have those conversations as a general rule with patients who may have a genetic predisposition towards addiction.
But you'd think, you know, it's from a preventative point of view, that if a family physician, I don't think there's many of them left, but if a physician, let's say treating a child or an adolescent, understood that in that family there were already issues. But I don't know that anyone ever asks if there is a family history of anything other than diabetes and in these medical issues, because they're physicians, and so they're about the health of our bodies. But the health of our bodies, our brain and our mental health is also tied to our physical well-being. And I'm not sure that physicians have turned the corner on making that association between the physical history of your family and the mental health and addiction issues of your family, and that the two may impact, or this may impact, the health of your child or your adolescent if the physician treating your children don't know that.
Absolutely true. And I will tell you that of the cases that are referred to us, and actually I can go back throughout my career and look at the cases that have been referred to me from medical practitioners, from general practitioners to specialists. None of them have come from clients or patients who self-report to their doctor, I have a problem. They come from doctors who see a physical manifestation of the effect of the addiction on the body and have a heart-to-heart with the patient and say, you have a problem and we need to figure out a solution to it. Even yet, that still sort of falls outside of the purview of what a doctor's express mission really is. So I think that most doctors are very loath to have those conversations. But that's absolutely an enormous part of where I think the medical community needs to go.
So looking ahead, where do you see your program going? How do you find referrals? How do you have relationships with people who say New Paradigm Recovery may be the place for you to go?
Most of our referrals usually come from one of two places. Local therapists and mental health practitioners in the area. And that can be anything from individual outpatient counseling to couples counseling or anything in between. Or residential treatment centers that get that they are not the solution, but that they are the first step in creating a longer solution towards recovery. So when we look for referrals, we don't have to look very hard, either fortunately or unfortunately. So the nature of the impact that we want to have long term is ensuring that we are staying on top of information as we get it socially, so that we are able to better treat our clients and make sure that they are staying sober for the rest of their lives.
Well, I appreciate you coming to my Rotary Club and sharing this, because that's how you came to me, was through my Rotary Club, and I hope you continue to do that kind of outreach to community organizations. Thank you so much for being here, Joshua, and this is what you need to know.